All right, so wanted to briefly touch on antiviral therapeutics, both antiviral drugs, small molecule, and monoclonal antibodies, because the theme seems to be, even though these are incredibly effective therapies that we've developed over the recent course of the pandemic, um, we don't seem to be able to get them into the hands of folks who need them. So they are limited, not by their effectiveness, but by our ability to get them out there. So similar to the effectiveness of a movie that stars Rob Gronkowski. Um, so the first study I'll talk about is this study that was recently published in the New England Journal, and it's actually a subsequent additional analysis on the major EPIC study that was done to provide data for the use of Paxlovid or nirmatrelvir and ritonavir uh, for treatment of COVID-19, and I'll remind folks that that study showed that there was an 88% reduction in hospitalization or death in folks who received that drug. So the drug is incredibly effective. Certainly was against, this is primarily Delta variant that it was tested against. Um, However, there's additional evidence that seems to still show evidence or still show effectiveness against subsequent variants. But what was interesting in this study was they released this secondary analysis looking at viral loads between patients who were in the treatment group and the placebo group. And they did a deep dive into viral loads to see if there were differences between the treatment group and the placebo group. And this is important because of all of the press and notoriety that's come around about Paxlovid rebound. And essentially what they showed is there was really no difference in viral load kinetics over the whole course of infection between Paxlovid and placebo, other than the Paxlovid treated group tended to have a more dramatic reduction in viral load, especially over the course of treatment. But you can see from the blue arrows that dip in viral load that occurred after day 5 and then rebound happened both in the placebo group and the Paxlovid group. And again, the red arrows, the upper curve, show that Paxlovid overall seemed to have a slightly better reduction in viral load compared to placebo. So this seems to indicate that um, viral shedding continues to occur for 10 days in many people. And the rebound effect really from Paxlovid is probably just a byproduct of Paxlovid reducing viral load earlier, and that's obviously a response to the antiviral. And then viral load tends to come back up a bit in folks after they've stopped the Paxlovid, but again, it doesn't come up to a level higher than what was seen in placebo, and so it's really just a reflection of the natural course of COVID-19 that we're just following more closely, probably in Paxlovid patients. I think this may be more pronounced with more recent variants because we've seen with BA2 and now BA4 and 5, shedding lasts even longer with higher levels late, after the first week of infection. And so you just may see a bit more pronounced effect there. But again, there's really no significant difference between Paxlovid and placebo, other than Paxlovid seems to reduce viral load more. So again, just highlighting the fact that the Paxlovid is working. There may be some room for an extended course of Paxlovid to extend that low viral load that we see late in there. But there's not really a Paxlovid rebound is the bottom line. And so all of the concern about not giving Paxlovid because of Paxlovid rebound is probably unfounded, at least based on this study. And again, this was Delta variant. Now, this has translated, unfortunately, I think, into a significant reduction in utilization of Paxlovid, or a lack of growth in utilization of Paxlovid. Now, this study was from a little bit ago not too long ago, in the journal Clinical Infectious Disease, that looked at all antiviral utilization over the course of the last year, essentially, of the pandemic a bit more. So this was a study looking at patients who received a positive result from a large laboratory that serves 37 states, and you can see almost 45,000 adults between March 1st, 2021, so over a year ago, and the beginning of August here. And the bottom line is you can see that in individuals age 65 and older, right? So these are folks who qualify as high risk. They're 65 years or older, seniors, and so they qualify for treatment with antivirals by all guidelines from the CDC and others. And you can see that the utilization rate has been horrendous, both for monoclonals and Paxlovid since the beginning of March of 2021. Fewer than 2% actually received an antiviral treatment. And you can see on the right, that's kind of the epidemic curve to remind you where we've been since March 1st. And so early on to the left of that arrow, antiviral availability was essentially the monoclonal antibodies. After that red arrow, when Paxlovid became available, so for that giant BA1 spike and then the large surge and plateau of BA2 and BA4-5, Paxlovid has been kind of the first line therapy. And so the majority of these cases would have qualified for Paxlovid. And yet again, you can see our utilization rate has been horrendously low. Fewer than 2% of, again, high risk seniors are receiving the drug. And so what we have is over the course of that time period since Paxlovid availability, and we're not even looking at, the impact of monoclonals, but we've had 200,000 deaths since December 21st. And the vast majority of those, at least if all of those in theory had been given Paxlovid, as we've seen from the data that I presented from that New England Journal, the EPIC study, we would expect almost 90% of those deaths could have been avoided if we had treated those folks early with Paxlovid. So we're doing a really bad job providing this very effective therapeutic. And it's not surprising because that test and treat pipeline is really a difficult one to implement broadly, but less than 2% is really a horrendous track record, and we need to do much better. A couple of final things I wanted to talk about, just briefly touch on. I don't know if folks saw, but recently, within the past 10 days, we had approval of the first two mucosally delivered vaccines, one in China and one in India. So these are adenovirus-based vaccines, which are administered by spray or aerosolization into the mucous membranes of the upper respiratory tract. And the theory is delivery of a vaccine by that route gives you better immunity. Delivering the vaccine and producing immunity at the point of entry of a virus, in theory, should provide you better protection. And the mucosal immunity that you get is a little different from immunity that you get if you inject a vaccine. Now, there's a lot of hype and hope about this, and hopefully it will be more effective, and hopefully also more effective in preventing actual infection and shedding of virus. That's something that in other vaccines, polio, for instance, live vaccines delivered by the mucosal route are very effective at blocking infection, whereas the injected inactivated vaccines in polio don't really prevent infection, but they just prevent you from getting neurolytic polio disease. So there is some precedent, but there's also precedent for mucosal vaccines not working very well, as in flu, where the mucosal vaccine actually in many people works less well than the injected, and for reasons we don't know. So I would temper enthusiasm that we're really not going to know the answer to these questions until we do more studies. Let's hope that it works, but we'll keep our fingers crossed. The last thing I wanted to touch on is just to remind everybody that emerging infectious diseases are still happening. And high consequence diseases are still spreading in new places. And that is testified to the fact more recently by the outbreak of Marburg in Ghana. If folks have been keeping track, there was an outbreak that was announced in July that seems to have not continued to grow. At least there haven't been new cases detected. And right now, the Ministry of Health of Ghana has declared that this outbreak is over. But ultimately, there were initially two cases that were detected, well, actually presented to care in June, but were diagnosed in early July, that occurred in the Asante region of Ghana. You can see that's in, kind of south central Ghana, close to Kumasi, which is the second largest city in Ghana. But these two cases arose from an area where there has not been reports of Marburg virus in that part of West Africa at all, and only one other incidence of Marburg virus at all in any of West Africa. And you can see initially 2 cases presented, and then later there was a child and a mother that were diagnosed a few weeks later. um, and if you look again, this was only the second detection of Marburg in all of West Africa. That belt across Central to Eastern Africa is traditionally where Marburg has been initially detected, coming out of Kenya. Actually, initially detected uh, in Germany, in Marburg, from monkeys that had been imported out of Kenya. But most of the outbreaks of Marburg viruses have occurred in Kenya, Uganda, and then very large outbreak in Angola and DRC. But this is kind of the first cluster of cases in West Africa. There was a single case detected in Guinea. And just demonstrates that we're still seeing new emerging viruses occurring in new parts of the world, and that this is always a potential threat to um, to be transmitted outside of the region to Europe, the U.S., Asia, other parts of the world, similar to what we saw with the 2014 Ebola outbreak. So again, just because there's a pandemic going on doesn't mean that other events aren't happening. And obviously monkeypox is another great example of that phenomenon. So we need to stay on our toes and recognize that COVID may be the most significant and severe emerging disease threat we've faced in 100 years. But it's not going to be the only one, even while we continue to battle COVID. So that's all I got. Thanks, Shelley.